Hello, my name is Mark Engel, and I'll be giving a brief presentation on NSAIDs and their use as an anti-inflammatory agent in their treatment of disease. Non-steroidal anti-inflammatory drugs, or NSAIDs, are a class of drugs used to treat acute and chronic conditions centered on the body's natural ability to induce inflammation and pain. Common examples are arthritis, migraines, dysmenorrhea, and musculoskeletal injuries. NSAIDs also have many other targets they affect. For example, aspirin, which also lowers platelet aggregation, is used at low doses as a prophylactic daily treatment for cardiovascular health. Both of these examples stem from how NSAIDs work and the mechanism by which they prevent the synthesis of many pro-inflammatory mediators called prostaglandins. As the name suggests, non-steroidal anti-inflammatory drugs are used as an alternative from steroid hormones or glucocorticoids. Glucocorticoids, while effective and still used today, are limited due to their extensive side effect profile, especially with sustained long-term usage. NSAIDs, while also having potential and important side effects, are therefore valued for their relatively friendly safety profile and efficacy. To further understand their role, let's have a look into the mechanism and action of NSAIDs. The story begins at the cell membrane, which is comprised of a variety of phospholipids. Phospholipase A2 are a group of enzymes activated by a variety of pro-inflammatory cell signaling factors. These are mostly bound in the fluid-like cell membrane and must make their way to select phospholipids to create their product, arachidonic acid. Arachidonic acid can then be fed through two major pathways, producing leukotrienes through the lipooxygenase enzymes and prostaglandins through the cyclooxygenase pathway. While leukotrienes are important with tissue functionality, NSAIDs act on the cyclooxygenase enzymes, so we will be studying that pathway further. There are two cyclooxygenase or COX enzymes available, COX-1 and COX-2. Both have the ability to react with free arachidonic acid. The COX enzymes produce the prostaglandin intermediate PGH2 and then move on to find more arachidonic acid. PGH2 can then be used down many different pathways through a variety of synthase enzymes. These produce many prostaglandins including PGD2, PGE2, PGF2-alpha, PGI2 prostacyclin, and TXA2 thromboxane. Each of these prostacyclins impact tissues in a variety of ways and cause the symptoms characteristic of inflammation. Increased pain and vessel diameter enhance the inflammatory response, and in situations where inflammation is destructive, they are the instigators of disease. Therefore, one of the main targets to reducing inflammation is to prevent their synthesis altogether by inhibiting their upstream enzymes. This is where our NSAIDs come in. They are COX inhibitors and prevent the COX enzymes from converting arachidonic acid into PGH2. This effectively blocks most of the production of prostaglandins. The first NSAIDs produced were non-specific and blocked both COX enzymes. At first, one may think this is great, as less prostaglandins will be made. However, due to the many actions of prostaglandins, there are a wide range of side effects caused by ubiquitous COX inhibition. One notable example is the occurrence of gastrointestinal ulcers. By inhibiting PGE2 synthesis, the protective mucosal and bicarbonate secretions are inhibited, and blood flow to the stomach is reduced. This leaves the tissue vulnerable to its own acidic environment. This is why, for example, aspirin, a non-selective COX inhibitor, should always be taken with a meal. However, there are new generation NSAIDs which only act on the COX-2 enzyme. Due to its larger shape, it cannot fit into the COX-1 enzyme, but is able to fit into the COX-2 due to its extra binding pocket space. What is important about this is that COX-2 is only upregulated in inflammatory tissues. Therefore, in other organs, for example the stomach, COX-1 is left unabated and can produce its protective prostaglandins including PGE2. In the disease-specific tissues, however, prostaglandin synthesis remains blocked and can improve the symptoms of inflammation. An example of COX-2 specific inhibitors is celecoxib, marketed as Celebrex. Glucocorticoids, as well as impacting a variety of immune cells, also act in this pathway by blocking phospholipase 2 and COX enzymes and their synthesis. This effectively prevents the synthesis of both prostaglandins and leukotrienes. Unlike glucocorticoids, NSAIDs are generally available over the counter. This is due to their relatively low amount of side effects. However, side effects can occur with overdosage and interactions with other drugs. As mentioned previously, non-specific COX inhibitors can cause stomach irritability, bleeding, and ulcers. Another infamous side effect is their potential for increasing the incidence of cardiovascular events, which notably removed Vioxx and Bextra from the market, but is not proven with the entirety of the drug class. Prostaglandins are used natively by the body to control kidney renal hemodynamics and maintain peripheral blood vessel tone. Therefore, there is an association between NSAIDs, renal toxicity, and edema. NSAIDs are not to be used in a variety of conditions where its drug profile would complicate issues. Due to its impact on kidney blood flow and reliance on liver metabolism, patients with diseases that impact these organs' functions may require a dosage adjustment. Others who suffer from poor blood clotting may be further affected by NSAIDs too due to the prostaglandin inhibition. Asthmatics may develop respiratory symptoms not only through potential allergic reaction, but also due to the fact that arachidonic acid is diverted through the leukotriene pathway instead, which contains potent bronchoconstrictors. Diuretic drugs and other with low therapeutic indexes which rely on renal excretion will have their dynamics changed by the renal influence of NSAIDs too. Since inhibiting prostaglandins produces an overall blood thinning effect, they should not be used with other blood thinners or glucocorticoids, as this will further increase these effects. Warfarin, a commonly prescribed blood thinner, also acts on the same liver enzyme CYP2C9, and therefore NSAID use may cause an increased response to many other drugs which rely on this enzyme to be broken down. Thank you for listening. I hope you learned more about NSAIDs and their role in treating inflammation.